a good panel coming up. So I guess the title of the session is The Role of Digital Health in Advancing the New Public Health Order, and this is part A of it. There will be a part B. I'll just introduce the moderator of this session, Mr. Brian O'Connor, and he's the chair of ECH Alliance. He's got quite an impressive profile, but he specifically asked me to not read it, so maybe I should. No, I'm joking. So just some quick highlights. About 10 years ago, he created with others the European Connected Health Alliance, ECH Alliance, as a collaborative way of breaking down the many silos that hold back innovation and better healthcare for citizens. Quite an interesting theme that's come across today. ECH is a not-for-profit organization which connects governments, industry, research institutions, health services, patient groups, etc. through a global network of ecosystems. Brian, please take the stage.
I did what all moderators should do. Before you get on the stage, you talk to the boss and you say, how long have we got? Now, because everything's running quite late, what we're going to do is it's supposed to be an hour and 20 minutes. We're going to try to reduce that to 1 hour, 5 minutes to gain back for AHB some of the time. So first of all, it's a pleasure to be here today. It's my first visit to Johannesburg. It's quite an experience for someone who's non-African. An Irishman at that, to turn up here and see just the sheer number of flights arriving here in Johannesburg, and to realise therefore how connected you are to the world. During this session we'll be asking, how well connected are you to the world in health? Transport's one thing. Looking at other systems across the world is a different matter. So, but it was nice to see that yesterday. And I learned another word yesterday, by the way. I was telling someone earlier, when I got a lift from the airport with Emmanuel, I said, where are you from? And he talked about himself. He has a farm in Zim. Now, you all know what Zim is. I had no clue. I thought, I'm sure I must know most countries in the world, at least by name. I'm from Zim. I said, is that near Mars or... So I had a brilliant conversation with him. I've also told him that he has not very good ideas. He wants to find a second wife. And I said, you're better with a mistress. People tell me that's true. I wouldn't know. So just to say, we have a very exciting panel today, and I'm going to ask them to join me on stage. What we're going to try to do to save the time is not to necessarily read out the very impressive CVs of each of them. A, it takes too long. And B, I think you'd much rather hear from them. So I'm going to ask the panel if they could join me here on stage while I introduce them. So Lutz, do you want to, if you would like to join me on stage? We need to do things in parallel, not sequence. Basuma, where's Renee? There you are. And this next lady, I had real difficulty trying to pronounce your name, as you will understand when we see the names on the screen. So I'm told you go by a number of names, but there's one name in particular you're happy to be known as, which is, I think it's Tumi. What is your... I realize, what are your friends called? Tumi. So as an Irishman, I can only cope with short names. So it's Tumi, it's Wasumi, Renee, and Lutz. So what we're going to do is we're going to take them in the order you see on the screen. I've asked each of them, and I've asked a lot of you, about this new public health, public order. I have to be honest and say, most people say, don't know much about it. We don't want to hear that, but it's true. How is it going to affect your business? Most say, as I don't know much about it, I don't know how much it's going to affect my business. So I'm not sure you're going to be any wiser by the time you finish this session. But my objective as the moderator is to try to get some answers, some comments and views. Each person is going to speak for up to 10 minutes maximum. And then we're going to try to encourage all of you not to sleep after lunch, but actually to ask questions. If you don't ask questions, I've got questions not just for the panel, but for you as well. I don't think you'll enjoy the questions, actually. So let's begin without any more ado. So it is a real pleasure to start the introductions, and I think the first up, if I remember, is Wasuma. I think you're the first. Wasuma, thank you.
Okay, thank you. Good afternoon. Hope you're all well and well fed. Okay, so my name is Wasuna Owino. I'm a health economist by profession and currently the country director for Farm Access Foundation. And so I have a few slides to share with you. So just to start with, Farm Access is actually an international development organization that is dedicated to improving access to affordable, quality healthcare. We do have 5 offices, with the main office in the Netherlands, Ghana, Nigeria, Tanzania, and Kenya. In total, we have about 220 staff, 70% of whom are actually in Africa. And since morning, we have actually been having a lot of discussions, and all these discussions are about market failures. We are talking about high out-of-pocket spending, high poverty, low quality care, limited investments in health, just to mention a few. So in this case, as Farm Access, we actually come in to address the market failures, which are actually characterized by the vicious circle of low supply and demand. So we provide digital innovations that are actually shaping several ecosystems in the region. And in this case, our audacious goal is to spark unprecedented gains in the sector. So in this case, as we see there, we actually leverage on the power of public and private sector partners and digital innovations to enhance access to care in the region. So what I'd like to do is just to take you through some of the things that we actually do in terms of innovations. So with the innovations, one, we promote equal distribution of resources. We lower cost of care. We enhance efficiency. We increase trust, transparency, and accountability. And we also promote evidence-based decision-making, especially in the use of dashboards. So the ultimate result of this is to have more care for the available resources, is to have better quality based on outcomes that matter. We also reduce medical errors using digitization, and we also bring care to those people who actually need it most. And one of our key innovations is the use of what we call the MTBA platforms. So for those in Nairobi, you must really be aware of the MTBA platform. So this is actually one of our platforms that connects the patients, providers, and the payers. It is cloud-based, and it digitizes and automates the end-to-end health insurance journey. It also promotes savings through a health wallet. And in Kenya, we are actually connected to 4.7 million people. And to date, we have actually been able to raise $45 million through that type of investment. So with MTBA, we also find that the hospitals are actually paid faster. Better rates are actually unlocked. There is increased transparency, and the patient is actually empowered. it is very, very important that in whatever we do, the patients are actually empowered. So we do offer several platforms for which I'll actually go through very, very quickly one by one. And one of them is actually on financial protection. So in financial protection, we actually work in a county in Kenya called Kisumu, and also in Kwara, for those who actually know that. So we work in several countries on the financial protection program. So in this case, one of the things that we actually do is to ensure that the patient's journey is actually tracked right from the time you actually enter into a health facility, the enrollment, the premium payment, the pre-authorization, the cash management and claims management, referrals, payments, and also dashboard that can actually be used. We also use MTBA for socio-economic mapping, which is really very, very important. So that is but one of the key products that we really have. Now, using also the internationally recognized SafeCare, we also enhance quality of care in many of the health facilities, and this is actually digitized as opposed to using a manual system. We also recognize that the health SMEs are actually looked into as risky businesses. So we also have the medical credit fund that provides loans to the health SMEs. We have both the traditional loans, which could go up to 500 million Kenya shillings, but you also have the digital loans that you can actually obtain within a period of about 24 hours to be able to address your liquidity issues. And what we actually do when it comes to care, we do encourage value-based care so that we only pay for the value of the services that are actually provided. So we do have both social propositions and also market propositions, and that we have found to be very, very critical. So in all that we do, more often we test and explore in the private sector. It's easier to do that. And we have our sustain or scalability in the public sector, which is very, very important. So if we look at the new public order, I think we really have a lot to offer in terms of how we increase resources, either through the medical credit fund, having timely payments, or using digitization in terms of getting increased capitation, and also in terms of respectful and action-oriented partnership. That is what we normally use for this scalability. Now, in terms of using digitization in areas such as remote care, telemedicine, and all that, now that enables us to make more efficient use of the resources that, the limited resources that we actually have at the moment. For the patient, it also saves time in terms of the transport, in terms of the movements from point X to Y. And therefore, the digitization, the aspect of patient empowerment is something which is very, very important. How do we ensure that you as a patient own your data, you are able to give a feedback on your data to providers so that they are able to improve on the respective services. So in a nutshell, we do have all those products for which I'm available for further discussions in terms of any of them, be it on financial protection, be it on quality, be it on innovative care models, such as what we have as the mom care, which addresses the safe pregnancy journey, having better outcomes for both the mothers and the children. And also, we do have a new a chronic care wallet, where we actually focus on hypertension and diabetes. Otherwise, thanks very much, and I look forward to more discussions and partnership with each one of you. Thank you.
Well, that was amazing. He's obviously a very good presenter because he finished within 2 seconds. You could have kept going for 2 seconds. So really well done. Because, you know, we often get speakers who say, I can get through 35 slides. How long have you got time to speak? 7 minutes. And you go, really? So 20 minutes later, you're still listening. But that was fascinating. And our next speaker is Renee, who is, and I'll read it this time, the Group Chief Clinical Officer at Mediclinic International. I spoke to her earlier and was fascinated by what she has done and what she's about to do, which is talk to us for 10 minutes. Over to you. Thanks, Renee. Thank you.
Good afternoon. Thank you very much. And it's a privilege to be here. Next slide. If I think of all the conversations that I listened to this morning and all the challenges coming from public health, if I think of our challenges in Mediclinic and the private healthcare, it sounds all too familiar. Next one, please. Next slide. So maybe I can tell you a little bit about Mediclinic. Mediclinic is an international healthcare group. We are represented in Southern Africa, South Africa, Namibia, the United Arab Emirates, Dubai, Abu Dhabi, and then Switzerland. So we have 74 hospitals. We've got 21 day clinics and 5 subacute hospitals. We run anything from primary health care clinics in the UAE and in our other facilities to very specialized hospitals. We take governance and clinical performance very seriously and really put clients or patients at the center of what we do. Next one, please. Next one. So if I look at digital health, why it's part, I think, of most healthcare providers' journey. So why do we want to look at digital health? And if you look at the challenges that we face with healthcare staff shortages, just over Africa, we know that we are vastly under-resourced, and that was stated a couple of times already. But it's not that we're under-resourced, it's also the resources are unevenly distributed across so some people are better off than others. But we also know that if we look at the training of staff, even if you have registered nurses, they're not all created equal. So the skills, the knowledge, the expertise, and what they bring to the table is very different. So we have, and it's not only in Africa, it's a global shortage. We're seeing the same in Switzerland, we're seeing the same in the Middle East. So we're especially amongst these very specialized nursing staff. Next one, please. The other big element that if we look at is fragmented healthcare. So we know that our funding models, the fee-for-service model that we have, mostly in Southern Africa, but even the DRG models or pay-for-performance value-based care, we have very fragmented healthcare systems. We don't have data sources that talk to each other. We have many versions of the truth if we look at the patient record. That contributes to a poor outcome on all elements of the value equation, from the clinical outcomes to the cost to the client experience. And we know that coordinated care, when we have seamless integration of clients and the information that moves along the care settings, that contributes to coordinated care and better outcomes. Where technology, data, communications, they are key enablers of the coordinated care. The next one, please. So if we look at digital health and why should we do digital health? Digital health is, digital technology of healthcare, but I also like the second bullet point that says transforming how medical professionals provide care, what patients do to receive it, and how healthcare systems operate. So it's not just about the technology, it's not about implementing a software solution, it's actually about how you change the way you work to improve the whole system. The one thing that we've done quite well with digital healthcare is in clinical governance. So we've got these three different, very different areas or countries that we look at, different healthcare systems. And we used to have safety event reporting systems, so patient safety foremost for us. But some of it was paper-based, definitions were different. It was extremely difficult to benchmark or to compare. So about a year and a half ago, no, almost 2 years ago, we implemented a standardized digital solution across all three divisions. It was painful, it was gnashing of teeth to get everybody to agree to the same definition, same taxonomy, but now we can actually compare. And if you compare, you see that the risks are actually the same. We want to believe that in SA the risks are different, but we see that very similar. So that has been a game changer. Next one, please. So if we look at the digital health trends, we know in the healthcare market that consumerism is up there. People want, they tell us what they need. They come to us with the requirements. We know that technology is really developing fast, that we're also moving away from sick care to health care, to actually providing all the other elements of care as well. In Mediclinic's journey to become more digitally transformed, we actually also spoke to the clients, and what the 20 to 26-year-olds told us that they want digitally sort of a ticket to the game, but the element that makes a difference is a human contact. So we thought that, but we never thought that would be the answer. Next one, please. Next one, please. So if you look at our digital health transformation vision, to us in Mediclinic, it's about universal access to all, is to really empowering people, not only the clients, but also the healthcare workers, to enhance efficiency, but to ensure the sustainability of healthcare. Next one. And the mission as well is to improve the access, the engagement, and the satisfaction, enhance the efficiency, and definitely to support care coordination that we see as really key. Next one, please. So I'm a fast talker, so this is my last slide. For me, the key points that I really want to highlight is that digital technology data is a key enabler of healthcare and a key coordination. We can't look at digital technology for the sake of the technology. It's about optimizing process, changing the way we think, standing back. And the really important part is that we need to include the voice of the client. We can't design systems because we think that's what people want. We need to ask them. And that we saw as an element of success. Thank you.
I did say 10 minutes for everyone, but it seems to me to think everybody has to be quicker. You don't have to be. If I could just pick on one point before we introduce the next speaker, just briefly. 5 years ago, I remember being at a conference in the States, and someone said, who will be the leaders in services for health in the future? And I suggested Google, Apple, and everyone laughed and said, no. Who are they? Yeah, they're big, they've got lots of money, but they're never going to replace us. Those comments came from people who think they own the health systems in different countries. And look at today, they've not been replaced. But actually, people like Google and others are definitely in the health industry. So we have to understand, and the key point you made, Rennie, was we have to listen. And this is the age of consumerism. It's no longer people saying, this is what you're going to get. This is the public saying, this is what I want, because we used it in every other thing we do. We wouldn't accept that from a bank, would we? We don't expect to go into a bank anymore, do we? Those are things that have changed, and sometimes I worry we're held back by dinosaurs, I think is the right word, or maybe as a politer word, I can't think of it, so I'll just use dinosaurs, in the health industry, who still think it's their health industry. I don't think it is. I think it's the public, not just the patient, but the consumer and the public. So having given my rant for the day, it's only 60 seconds of it, we'll now move on, and I'm delighted because I've spent some time talking to our next speaker and understanding what he and his company do. And I think it's a really refreshing to hear someone who's actually achieved something, as opposed to I'm going to one day do something. So I'm very pleased that he's going to talk about what he's actually done, and then you believe him when he says, and now I'm going to do the following. So without further ado, it's a pleasure to introduce Dr. Lutz.
Yeah, thank you very much for this nice intro. Thank you for being here. Thank you for organizing this event to AHB, of course. My name is Dr. Lutz Mücker. I represent Lectorio. Lectorio is a German private company, and the title here shows you what it's all about, empowering health systems through capacity building in digital education. Next slide, please. First, I give you a short intro about who we are, what we do, and why we are doing it, and then I brought to you, I can show you an example, a public-private partnership, which we have, or we are still doing in Ethiopia, and we very much believe in public-private partnerships, and I think that's the best practice example. All right, so this slide shows you about Lectorio. Lectorio is a digital platform or an online library or a content management system. Think of it how you like. We've been there for 15 years now, so well before COVID-19. It was a startup by 2 students from Leipzig. Leipzig is a very old university city close to the capital, Berlin. And today we are a real global player because we have very early believed in the digital education idea. So, like I said, we started with 2 students, and now we are active in 175 countries and have more than 2 million customers, partners, and organizational partners. What we have created is a very advanced teaching and learning platform. Not only the IT structure, but we filled it also with quality content. And those numbers you see here, this is massive content. So we covered the entire medical and nursing curriculum, and huge parts, of course, you can also use for a community health worker or health extension worker education, call it however. Just a few numbers, you see them, 14,000 educational videos. They are richly illustrated, animated, television quality. And our headquarters in Leipzig, we have branches in the US and in Bulgaria, all around the world. We are 400 people now, I think, and in Leipzig, 120 full-timers. And those are our production studios. And what we do is we bring, so to say, really from very well-known schools. You have a few logos here from Stanford, Yale, whatever, UCL, Johns Hopkins. We bring educators, they get a contract with us, they come to Leipzig, get a new, good, nice hotel, and then we produce together with them these contents you have on the platform. So we are based on certain philosophies, and quality, of course, is one of it. Otherwise, you could not market a platform for medical education. Yeah? Next slide, please. And here, that's one example. We have all kinds of partners. You know, really all kinds, private and public, private hospitals, public hospitals, university, faculties of health, nursing colleges, NGOs active in the health field, big private companies in the health field, small private companies. So really, it's a very colorful bunch of customers we have. And we do also public-private partnerships projects, and one of the biggest, I think, in the moment around the globe is what we are doing in Ethiopia. Here you have the project outline. The objective was to reach out to 8,000 medical students. I don't explain in depth here the constraints and budget difficulties and the extreme pressure many African countries and ministries of health have to work with. Yeah, but that also goes along with a certain mindset and innovation openness, which, by the way, we don't find so often up north. All right. So we wanted to reach out to 24 medical schools and to approximately 8,000 students. Next slide, please. And we wanted to achieve a systematic empowerment of the students as well as of the lecturers. So the advancements, we were focused on 3 aspects. It was content, of course, learners and training support, and also the support of educators and trainers. Next slide. And so that was a public-private partnership. I mentioned it already between us, between the Ministry of Health of Ethiopia and the GIZ, yes, a very well-known German development aid agency. And what we developed for all these 25 medical schools, or even more in the end of the day, was they all got dedicated academies. The curricula were mapped into the platforms. Next slide, please. They could use the contents on the platform already. Next slides. Yeah, and we also did joint content production. Here, an example of 50-something courses we did on equipment use and maintenance. Very, very important topic in many African countries. Next slide. The platform itself, it's, I mentioned it earlier, it's really advanced. The analytical part of it is really fantastic. So you get out of it a lot of analytical data about the performance of the students, but also of the performance of the educators, which makes it a very powerful management tool. You see the weak points, you see the strong points. You can, and finally, you can ask the question, why is that and that? And the answers, of course, are with the management and the decision-making, the adaptation on it as well. Next slide. Next slide. You just click through the graphics here. So the outcomes were for us very successful. So we managed in a very short time, under extremely difficult circumstances. So within 1 year, we managed to equip 35 instead of 25 schools. We reached out to almost 10,000 students. The satisfaction of the educators as well, next, you just click through here. The educators as well as the students was very high, and the difficult circumstances we established, the complete project was COVID-19, the war in Tigray, and local elections. And that's quite something, And of course, you see this quarter where there are difficulties and not satisfactions had very often to do with power shortages, connectivity issues, and that like. Next slide, please. Yeah. And because that project was such success, so to say, we now expanding our digital large-scale capacity intervention in Ethiopia to the health extension worker system. So we are going now on with the Global Fund. It's again a PPP, Global Fund, Ministry of Health, and Lectorio. And now we are going to equip 18 educational institutions and do in-service trainings, even in the far rural hinterlands, with the dedicated online academies. The course topics are also, go back please, course topics are also interesting. Of course, this platform or Lectorio is not a closed job. We always customize and tailor it according to the needs, and these projects in Ethiopia, like I said, joint content production is a very important part of it. And here we are focusing on family health and family planning, immunization, cold change, health statistics, and very important, how to do a survey. So to enable health extension workers to provide statistics and data from their surrounding. Next slide, please. And yes, so what is the role of the private sector in the African new public health order? I think digitalization, our example shows that we are very inclusive, very accessible, and high quality. And these interventions can be done fast. We don't need 400 years, that number was around last evening and this morning, to educate. We can do this within months and years. We can install these digital academies within months. The contents are there. Joint content production is also no problem at all. It's not a closed box. It's always a collaboration. And here are some more points. You know, it's highly cost efficient, highly cost efficient. And it's also a momentum of global democratization of education. You remember one of the first slides showed all these logos from Harvard, Yale, Hopkins, and so on. And I love the idea that the students and the community health workers in the far rural Ethiopian hinterland have now Harvard professors. It's fantastic. And that's the end of my presentation. Thank you.
Well, I did say that he had done a lot, and they have done a lot. So there are a lot of lessons from that, aren't there? That the 400 years is nonsense. Some of you may still be around in 400 years, and you tell us if you're wrong. I won't be. What I would say is that's an example of doing as opposed to talking. And I think... So I'm very grateful to our panelists, not only for sticking to time, but actually giving us examples. Our last panelist, very interesting, when I read her long bio, we have a qualified pharmacist here. We have, above all, a female entrepreneur. When I read all of the things that she's done, and she still feels it's time still to go for her doctorate. I don't know where you're going to find the time to do that, but good luck. So I think listening to it, I'm going to attempt to pronounce her name, and if I don't do it right, well, I don't do it right. So I think it's, get this right, Botemello? But very reasonably, come on, for an Irishman, it's not bad, you know. So please, over to you. There you go.
Thank you, Brian, and to everybody who is the first time to come to South Africa, we say welcome to Mzansi. My name is Botemello, as introduced. I'm a pharmacist by profession. I qualified over 23 years ago. I worked in different sectors for 16 years up until I surrendered to the entrepreneurial call. Over 267 million individuals are not using internet in Africa. That translates to 53 million households. Within these numbers, there are substantial inequalities between male and female, youth and mature, upper and lower income groups. An estimated 30% of sub-Saharan population is beyond the reach of backbone network, let alone last mile to access to internet. According to Alliance for Affordable Internet, African countries also have the most expensive broadband in the world. The first gigabyte of mobile data cost 9.3% of the average income in 2016, compared to 3.7% for Latin America and 2.5% for Asia. Second slide, please. You can see on this slide that Middle East and North Africa are coming in third at 78%, and we are the Sub-Saharan Africa, we are coming in below world average at 30%. Over 10 years ago, almost all of Africa had minimal access to the internet, but 10 years later, we can see progress, but still a dire situation in terms of internet access in the African continent. In highlighting the efficiency gains through adoption of digital health and services in the era of technology, this will help us to understand the disease profile better. It will also improve better outcomes for patients, and it will also introduce better tailored, high quality, and more accessible treatment. In giving example on better tailored treatment in my pharmaceutical industry, we have imaging, which is X-rays, which when we use algorithms, they diagnose accurately than human doctors. We have chat boxes in the rheumatology sector, where it pumps up patients' literacy and informing them about the disease. Wearable devices, which shows inflammatory markers, ingestible sensors for drug adherence, and also genetic sequencing for personalized therapy. Healthcare is not only impacted by AI, does not only impact the healthcare industry, but it does affect other sectors, the agricultural sector, public services, and financial services. Next slide, please. AI will boost productivity dramatically by maximizing output and growth. As a new factor of production, it will drive growth in health information systems by intelligent automation of workforce, that is the ability to automate complex tasks that requires human abilities, for instance, pharmaceutical warehouses. It will augment labor and physical capital, drive innovation, reshapes how work is done, and improves efficiency, and accurate allocation of resources, and increased productivity, especially for our ministerial officers who does budgeting and forecasting. Next slide. National medical system often suffer from central challenges such as shortages of healthcare professionals and supplies, accessibility barriers, urban and rural, lack of awareness on health issues, and affordability. AI can plug the gaps by developing disease surveillance and monitoring, which will empower and supplement staff, improve public health policy, improve healthcare delivery, better diagnosis and detection, improve access, and tailor medical intervention, as I mentioned in the previous slide. Next slide. In trying to differentiate between the different interventions with telemedicine and remote care, telehealth obviously does not include the clinical factors. It takes into account the non-clinical interventions with emphasis on preventative care, health promotion, administration, and education. And telemedicine would focus on clinical intervention, and the patient overall outcome would be measured. Next slide. In adopting these initiatives and in offering care via virtual consultation, concerns were noted between the patient and the healthcare professionals. And these were the common concerns. Confidentiality. In South Africa, POPIA Act was enforced last year to protect the right to privacy, right to access to information, right to freedom of expression, system accuracy and security, electronic transmission, which most providers have actually tried to protect data by using password and secure authentication techniques, reimbursement, scheme support and policies, and liability issues. The next slide just differentiates between the concerns between a patient and the healthcare professionals. For the patient, you can see that they are saying most of our healthcare professionals do not actually offer telehealth, and my scheme does not pay for it. Private security, technical, and wrong diagnosis. For our healthcare professionals, reimbursement concerns, technical, obviously security, scheme support and policies, and liability issues. In my young days, when I started out in pharmacy, I got an opportunity. I actually had a pharmacy practice for 10 years, and I got an next slide. I was actually one of the pilot site of the Central Chronic Medicine Dispensing Distribution, which was discussed in our last session, where they unpacked the program. The program aims to just decongest our hospitals by distributing stable patients to go collect their medication in community pharmacies. And what the government has also done is to introduce electronic vaccination and data system, which was done during the COVID vaccination era. And this initiative actually supported COVID-19 vaccination rollout and to capture vaccination digitally and provide data analytics platforms to monitor and report on. Where are we as South Africa? The South African, next slide. Next slide. This is another example of the flagship project in South Africa, the Mom Connect, which focused on antenatal and prenatal women. And as of 2019, 2.5 million were registered on the program. So it was a flagship project that actually was done successfully. Next slide. Where do we stand as South Africa? The South African National Strategy 2014 highlighted the following two priorities: development of a complete electronic card and digitalization of health system business plan. And it highlighted the following: that we need more investment, we need improved service delivery, we need patient outcomes as per SDG for health, effective collaboration, and decreased data costs. Next slide. So who are the team players, the collaborative approach stakeholders? Obviously, this includes policymakers. The policymakers will assist us in defining the governance and the legal framework, and ethics, consent, privacy, ownership of data, samples, and commercialization. Academia, curriculum to healthcare science students, plus research. Industry, we need development, investment as a form of private-public partnerships, and commercialization. Civil society, we need it for network, accountability, and inclusion. And the international community to be able to assess best practices and platforms of discussion. The recommendations, next slide. Recommendations is that we need private investment, especially in Africa. Adequate infrastructure, new wireless technologies, affordable so that it can address our equity and socio-economic skills shortages, bypassing in some cases expensive terrestrial infrastructure. And I challenge the AU and CDC to finalize the governance and legal framework. Community literacy and research. Our research needs to be diversified, because most of the researches that I learned about university, it was based on a 17-year-old white male, and Africa is a diversified community. In conclusion, the cost to action, next slide, is the patient. Who is this patient that we're trying to service? This patient could be disabled, this patient could be blind, this patient could be unconscious, this patient could be deaf. We should focus on the caregivers who at some point, they need tools to make decisions for their loved ones. Healthcare professionals, we need to empower their data literature. Private and the public sector, we need to ensure that all the citizens have access to both systems. And the healthcare system, we need to enforce ethical policy to ensure that it's fair, it's safe, it's reliable, private and secure, inclusive, transparent, and accountable. Thank you.
It's great to meet speakers who not only stick to time, but are precisely on time. There was literally not 1 second left, so very good. I wish we had you in Europe, because I tell you, in Europe, forget it. Anyway, so let's begin. We have an opportunity now to raise questions from the audience. I know you're not shy, because I've heard you ask lots of questions before. Rather than stand up, though, and make a statement or make a speech, I'd really like specific questions to any one of the panelists or to all the panelists. So if I could open the floor now for the audience, if you have any questions, now's the time to ask. Lady there, followed by a lady there. So can we start with this lady on this side, if you've got a microphone somewhere, just coming to you now. And then the next one will be this lady here. It saves time if you've got a microphone ready there as well. Just the lady in the front here. Please.
Thank you very much for such an inspiring talk and actually giving us hope that 400 years is too much. We can do it in a shorter time. My two questions. The first one is that most of us, especially in policy decisions, we are the baby boomers, not technology savvy. How are we going to convince those people that this is the way to go? The second one is that, especially with what the last speaker has just spoken about, connectivity and cost is a problem. But even it's not about that, all of these things, we have so many dependencies that the other people who must help us, the medical aids, the regulatory bodies, in South Africa, HPCSA, in terms of doing that. At what platform are we dealing with that? Because we can have these PPPs, but if those two things are not dealt with to try and improve the number of skilled people, the technology that we need, the response to what the current need, people need, as an entity, private sector and public sector, I don't think we will win. So are there any strategies, or what else should we do, all of us? Thank you.
Thank you. Do you want to have an attempt at that second question? Do you feel able to do that?
No, I think.
There's a microphone next to you on the right-hand side.
It's just a comment. I don't know if. Can you hear me? It's just a comment and adding to what we have. Okay, somebody else can take it.
Try that. See if it works.
Okay, it's just a comment, and actually in addition to what you have highlighted in terms of, I think I will direct it to one of our speakers, and I'll actually ask the same question. Our healthcare professionals, they are so overwhelmed currently with the amount of work coming towards them. So what can we actually do to ensure that they have time to accommodate these new innovative technologies, and also addressing simple issues like road infrastructure and electricity issues?
And then once you can sell that value proposition, then people are more keen to actually embrace the technology as well. So the technology sort of comes as a second one. Maybe a quick analogy, if one looks at nursing staff and the levels of training, that's not the same. If you are lost in a desert and you are really skilled and expert and you can use the stars to navigate and actually get out, you'll be safe. If you're not, you might die. But if I give you a GPS and I give you the technology to actually get out of the desert safely, you will be fine. And I think that is the role that technology plays in healthcare workers. So if we have nursing staff that has a challenge, we won't make them skilled, we won't make them experienced necessarily, but we can actually empower them and make them skilled to do the job that they need to do. So I think that is just one thing I wanted to add.
The lesson from that is, first, don't get lost in the desert. There are no signals, but thank you for the analogy. Can we take the second speaker? I have another speaker over here afterwards then, please. Please go ahead.
Given the adoption of digital within the public and private healthcare sector, do you think we should be focusing now on adoption of patient data? So in other words, that the patient actually carries around a health file, so that you also limit duplication of healthcare services when patients are moving between public and private, or private and private, because there's very limited data sharing?
Who wants to take that one on? Do you, Asuna? See if your microphone's working. Yeah.
Yeah, sorry, I think in terms of that question, I think the emphasis should actually be on portability of patients' data, so that whichever place the patient goes, the data is actually there to be able to make timely decisions. I think that should really be the focus.
Anyone else want to jump in? Rennie?
Yes, I agree with your comment. I think the other important aspect is that one has to have one version of the truth for patient record. Because if you have fragmented care, you tend to make the wrong decisions. So having a patient carry that record is a very good idea, and I think it's something we really need to move towards.
We have another question here.
Okay, thank you. Edwin Muller with Village Reach. First of all, just want to appreciate the panelists, very great work that everyone is doing. My question is specific to Dr. Lutz and the great work you're doing on the building the capacity of the health workforce. is there a way that you are able to measure the impact of these capacity building efforts on healthcare service delivery? Is it actually impacting it positively? Are you able to measure that?
Definitely. I mean, you can do some surveys on that. You know, after a while, you can definitely measure that. I'm very sure, because I'm sure that you can definitely measure it. You can also already measure it within the intervention, because, like I showed you this screenshot, you know, of the analytical dashboard of the platform. Is delivering all sorts of aggregated data about the performance of the students, of the lecturers. You can, you know, use it for whatever analytical questions you have, and the outcome after the intervention, it should be, that's an empirical question, you know, for an empirical researcher, of course, but it's a complex design then, yeah. But of course, I mean, if you invest in education, there should be an outcome. Eh? That's the whole meaning of it. Yeah? And I just wanted to add a footnote to your question. The world is really complex, and from our experiences, you know, it's all about making statements, contributing to the discussion, participating in the discourse. And we have the umbrella organizations, even of students, of lecturers, of universities, and so on. And they can raise their voices, and they can do awareness raising for this topic, and they can demand things from their governments or from their MOH or whatever. But we don't see that negatively. We have very positive experiences, even with the, not even with the ministries of health as well, and other education public bodies. So the innovation openness is there. And maybe, you know, we had this in our pre-discussion, you know, that this ideological, you know, talk about public and private, maybe it's a bit overdone, because we are constantly in all fields collaborating, and we have to, you know, because innovation is very often produced by the public sector, of course. But even in that field, I see very positive developments.
Thanks very much. Before I ask, I've got a question to ask. Before I do that, anyone else? There's someone at the back, and then come to you. So one at the back, one here.
Sorry, thank you.
So you jump in. I'll wait for my question. You carry on.
Okay, we'll go. Hi, I'm Michael Reed from Gilead Sciences. I just want to start by piggybacking off a question presented to the panel, but asking for more specificities. You know, we're very clear that, you know, vertical digital programs, you know, they're great for your own institution, but how do they integrate laterally? So with Pharma Access, how do the mobile and digital technologies integrate with the existing or the emergence of the health management information systems in the institutions that you are working around? From a Mediclinic standpoint, how is this integration going to be achieved in the Mediclinic value chain? So we've got patients being referred from primary care into the Mediclinic hospitals, but at the same time people are being discharged into additional care that may be out of the Mediclinic systems. How do you then integrate those sort of digital technologies and advances? And the last question to is it Lecturio? My question is around the tactile component of developing competencies in medicine. So we talk about you see one, you learn one, you do one, and you teach one. The do one component, requires, actual, physical, as I say, tactile component. You may have mentioned 70 clinical simulations. I don't know if this is the right area, but could you please elaborate on how you satisfy that component? Thank you.
Thank you very much, and very good in getting in 4 questions in one. Well done. Rennie, do you want to answer the first one in the Mediclinic? please, first, and then come to you, Dr. Lutz, afterwards, please.
Thank you. It's a good question. Coordinating care is not an easy subject, and the coordination is also not linear. It's actually a complex adaptive system. So Mediclinic has just embarked on a journey to improve the coordination of care, because we have the challenges, but also having access to the care of patients, even though they are discharged or discharged into another care setting. And then obviously, in future, looking at electronic health records, that would empower us and actually allow us to do that. But we've embarked on the journey, and we're setting up the systems to be able to do that.
Yeah, there were, I think, two aspects for me. Thank you. First of all, the integration in already existing setups. You know, whatever most of the institutions and organizations work with: Moodle, Blackboard, Canvas, and so on. From our end, it's really easy to answer. Lectorio is integratable in both ways. So in these setups, as well as you can integrate the contents from Moodle into our platform. The second question was, of course, digital education can never, ever substitute real-life education in the hospital or with the patients. No way, if I understood you right, you know. But as everybody, COVID-19, I don't repeat it. It has been said so often on this date already. But the whole understanding and the whole implementation of digital interventions and idea and strategies, they are there already. Everybody is searching for a way to implement something, you know. And we have, from our experiences, we know that some teaching organizations are going for 20%, others going for 70% online. And that's manageable, you know. It is just a question of your strategy. We have, for instance, a big customer in the US. They bought us even before they started to offer medical education. And then they assembled their live teaching and live education around digital. So you have all kinds of different answers to that according to the, you know, the real life examples. Yeah, thank you.
Thank you. So do you want to jump in?
Yeah, I think the question on data integration, I think I would like to address it. It's a challenge. I would really say that because of either self-interest, it could be an issue about cost, or it could be an issue about regulation. And we have actually attempted to plug into KHIS, which is the same as the DHIS, with good success. With the National Health Insurance Fund, we got some bottleneck for obvious reasons. But what we are actually working on now is in the ecosystem where we're working in Kisumu, we're actually trying to plug in all the data to a county data warehouse for which you're actually providing the architecture for that. Now, once we have this, then this is now going to be plugged in to the National Government Control Center, which is actually, for those of you who know, is in Konza City. So that is something which is in the works. It's a challenge, and for Kenya, we do have, health is devolved. So we do have 47 county governments with different solutions, you know, in the 47. So it's not very, very easy. But the lesson we have learned for us to succeed, one, is any data that we provide must address a real need. And that really ties to the first question. It must really address a real need to the policymakers. Number two, it's key to have a champion to be able to support you in the process. And we have also learned that co-creation of these solutions is very, very key. If you do your own products in the West and you are coming to plug it in, it will not work. There will be that type of resistance. And then there should be joint resource mobilization for scalability. So make the government part and parcel of the whole thing. And then in that case, we'll be able to address the issue about the policymakers and at the same time, we'll be able to get that interoperability. But it is a challenge.
Is there a microphone? Sorry, with you next. Didn't see your hand up. It's too many lights. We'll start with you. We'll definitely fit you in.
Okay. I liked very much what the previous person asked the question. He said, see one, do one, teach one. And that's, that's a creed of medical school and, those of us who are doctors. But just to take a step further, the question is, can you see one, do one, teach one, and fund one? And this question is for you, Boitumelo. You made a very nice example of a primary healthcare M-Health technology in M-Connect. I use it myself. I think it's fantastic. Because the NDOH saw it as an innovation, it was, at its inception, funded by private funders, industry, philanthropists, etc. In order for it to become sustainable, the NDOH needs to be the one to continue to fund M-Connect and any other M-Health or e-health technologies. So just trying to figure out what is your perspective or your opinion on how to create the budget headroom from a National Department of Health, a Ministry of Health, in order for them to keep funding these really impactful M or e-health technologies.
Okay. I think in that the departments really need to understand the need of the patient on the ground. And organizations like myself, On Point Healthcare, I actually do health risk assessment, focusing on the quadruple burden of disease. Simple: HIV, hypertension, diabetes, cholesterol. Just to give you a case scenario, if I go to private clients, for instance, because of the technology and the innovation, and they are using, and we have connectivity, I know how to staff what type of personnel do I send there and how many nurses do I send there, so I can do my calculation. But should I go to a mining community, it affects my budgeting, my planning time, my travel time. So I think on the government side, they need to engage with us providers who are on the ground, engaging with ordinary South African citizens, I guess, at that point.
We'll come to, you've got a microphone. Another question, please.
Hi, good afternoon.
We can hear you, I think.
Hello?
Okay, there's another microphone.
Hi, good afternoon. My name is Yvonne Chepkonga. I'm the Government Affairs and Public Sector Leader for Medtronic. South Africa and Africa as a whole is a world of contrasts. We are a first world and a third world rolled into one. One of the speakers that spoke earlier made a point that about 4.5% of the population in Africa, and maybe in South Africa about 20%, they have private medical cover. So my question will be directed to you, Dr. Toa. In terms of Mediclinic, what role do you think you can play in trying to actually expand your services just, wider than that 4.5%, and actually make sure that you actually are making a contribution to the public sector, which services the 95% of the population? And the second question is, we learned earlier that in terms of the resources, especially the nurses, I mean, it's almost like a dying breed, if I may put it like that. And we know that in South Africa especially, a lot of the nursing colleges, have been closed down. So what does your organization, plan to do to actually make a difference in that space? Thank you.
Thank you. Thank you very much. It's really important questions. Mediclinic supports the sustainability of healthcare and really increasing access to healthcare for all. So it's not just about servicing a very small percentage of the population. So we are looking at creating more affordable, and we have creating more affordable healthcare packages, and also understanding and supporting different healthcare needs. If you look at the Njani clinics, that's also part of Mediclinics, is supporting some of those clinics as well. So we understand that we need to look at healthcare differently for everybody, and not just for a small group of people that can afford private healthcare. In in addition, we also need to look at the cost of the cost of actually providing the healthcare, so that we take the waste out of the system, not the quality, but the waste out of the system, that we can do more with the money that we have. So I think that's really important. I forgot your second question. Won't you please just... The training, yes. Mediclinic has nursing training schools, so we have been actively training, but we have been limited in the numbers that we're allowed to train by the government and by regulations. That's something the whole private healthcare industry in SA is actually engaging with government and regulators to allow us to train more. Thank you.
Any other questions? We've got 4 or 5 minutes left. Don't want to cut you off. There's someone there. There's a microphone coming to you. If you could ask a question, or questions, as everybody does. Please, go ahead.
Okay. Thank you so much. Good afternoon. I am Adrienne Losa. And I have 2 questions. The first one is directed to Dr. Lutz of Lecturio. So I really appreciate the work that you're doing. Once upon a time, myself, I wanted to be a pharmacist, but when I finished high school, there were no schools of pharmacy training in my country at the time. So making access or giving access to health education is really important work. But I'm curious about your slide where you showed where the lecturers are coming from. I don't know whether the objective was to show that there were people from Yale, Harvard, but I didn't see any African universities on that slide. Do you work with educators and universities on the continent as well? Because I think it's important to have them also. I had to move from Cameroon to South Africa to get educated, for example. There were schools in Nigeria, but I couldn't access them because of funding, and there are other challenges there. But I'm just curious, with your experience and with the work you do, are there barriers you can speak to of, having universities on the continent also distributing access to this education? Or is it just a matter of choice? I'm really curious about that. And then, yes. Okay, sure.
Yes, of course. I mean, I implemented these logos to show kind of quality level we have there. So quality, I think I mentioned it. That's first. That's the must have for us, otherwise you could not market such a platform around the globe. That's why the logos are there. We are partnering with literally hundreds of universities. Here in South Africa, we have partners. We have across the continent in Africa, many partners. We localize the contents. It's not a closed box, the platform. So like I showed one slide showing for equipment use and maintenance that was done together with educators from Addis Ababa University and so on and so forth. Of course, yeah, it's not kind of a new colonialism bringing the contents again from the north to there. No. It's really, join forces, customize it, tailor it according to the needs, and the needs assessment is very important. That's a process. You stick together your heads, and you tailor whatever is necessary. Yeah. Does that answer your question?
It does. And maybe as a follow-up on that, the skills education that you do, is it full-on curriculum for, medical school, or do you do short programs? And you mentioned quality. If someone were to co-create with you on content, do you enable, the quality, or is it people need to come already with the quality standards that you require?
That's, the last question is really a nice one. Do we enable? Yes, I think we do, of course, because when we do co-production of contents, that's always teamwork. And that's also something new in digital content production, These big names come to our production studios, these professors like some of you might know, you are from the same heard, so to say. But they come to Leipzig, to our production studios, and they are the kings of their field, you know, and they think they stay in front of the camera and then they do whatever they have done before. No, it's not. Every little sentence, whatever they do, every graphic animation, it's all teamwork, even the clothing and so on. That's a completely new way of production of contents and in the end of education. Yeah.
Could I jump in?
But there was a second aspect.
I was going to say, please. I want a question first. Are you open, therefore? I think part of the question is, everybody wants to make sure that there's African contributed content, if that's the right way to put it, that is not simply from overseas. Please.
Yes.
Please.
Yes. Yeah. A big yes. But you must understand that we don't educate. We provide dedicated white label accounts to institutions. They put their logo, their names, whatever, to the platform and use it for their own teaching purposes on every scale. So we have private hospitals, they do their in-service trainings with us. We have NGOs, they're doing small summer schools for awareness-raising malaria with us. We have medical faculties, they do all the 6 years medical education with us. And in between everything, nursing education on all scales. Yeah? And it's really a question of the needs of who you are, what you want to educate in the health field. Yeah? And also to mention a weak point, we are very weak on dentistry.
So any dentists in the room or connections with dentists will then be talk to him.
So I have a question for you, Brian.
It has to be
short.
Yes, not a quick question. It's going to be a very quick answer.
I would like to find out, with your experience at ECHA Alliance and the Digital Health Agenda of Europe for 2030, what sort of quick top of mind things should the African health ecosystem be putting in place so that we are aligned? Because a lot of the digital solutions will also come from outside Africa. But what should be in place so that we are aligned with such programs like the 2030 Agenda?
So my two quick responses are, number one, you should stay in this room because very shortly we're going to be having an AHB ECH Alliance quick session. And we will explain more about what the Alliance is capable of doing. Second, we're not here to tell you how you should do things. We're happy to share our experiences, which is not colonialism. Again, it is, and I'm Irish anyway, we never had an empire, which is why most people like us in the world. So stay in here and we'll ask the questions then. We need to wrap it up now, I'm afraid, because of timetable concerns. But may I just say, can you join me, please, in thanking the panel? It was really excellent. Well done.